We're now going to come to the most burning topic in the country, which is GLP-1.
GLP-1.
DLP-1.
GLP-1.
The gym has always been a place to go and make the Salman Khan type of a body and, have these pumping arms. And if somebody comes and tells you that, I don't want to get these bulk arms,
Yeah.
etc.
When I started working with patients in underserved areas, it was a clear link between diabetes, high cholesterol, heart disease, obesity. If we could control that, a lot of the other comorbid conditions would also improve.
We all have somebody in our family who's suffering from obesity, who's trying out everything which they can. Sometimes they don't have the right answers. Sometimes they don't know who to go to.
When I got into obesity medicine, and I think why I got in, it started very early. I actually have a very strong family history of obesity in my family. And I saw all the comorbid conditions associated with diabetes, heart disease, the cancers.
Dr. Roohi, can you tell us a little bit about your story of how you started and how you got into treating weight and obesity?
Absolutely. So, first of all, thanks for having me on, Sahil. So, a little bit about myself. I did all my medical education in the US. I was born there, raised there. Got married to a guy from Kolkata.
Sure.
And we decided to shift back with our family. But when I got into obesity medicine, and I think why I got in, it started very early. I actually have a very strong family history of obesity in my family. And I saw all the comorbid conditions associated with it, the diabetes, the heart disease, the stroke, the cancers. So was exposed very early. I always knew I wanted to be a doctor. And I went into initially primary care and family medicine. And then when I started working with patients in underserved areas, it was a clear link between diabetes, high cholesterol, heart disease. It was obesity.
It's a very prevalent issue, yeah.
It's a huge thing. And if we could control that, a lot of the other comorbid conditions would also improve. I'm not saying cure, but they would improve. And a lot of the patients needed counseling. That's what they really needed, along with medication. This field is fairly new. Now it's completely blown up in my recent experience that I'm seeing. Everyone is practicing obesity medicine now. But I started learning on my own. I think the passion grew from there, from my exposure and then my patients. And then I applied for a fellowship for obesity. I remember I was pregnant with my son, and it was COVID.
Oh God.
And I said, oh my God, my fellowship. So they moved everything to online. But anyway, we got trained, we got exposed, and one thing led to the next. And I think my true passion of trying to learn about it really helped me in kind of finishing up my fellowship and training. But that's how I fell into obesity medicine.
Well, that's great. And if you think about it, like we all have somebody in our family who's suffering from obesity, who's trying out everything which they can. Sometimes they don't have the right answers. Sometimes they don't know who to go to. And traditionally, I've seen that, like for the past few years, as you mentioned, that it's blown up right now, especially the field of obesity specialists. Before that, a nutritionist or just a strength coach or like a gym trainer used to be there to help with this. But that wasn't working out that well. So, is there any specific reason why this shift to specialists has come from somebody more general for nutrition who used to maybe so I used to, my father, my grandmother all used to go to the same person, which I feel now is changing. So then why is this shift happening?
I think there's a realization, number one, that obesity is now considered, but always was, a chronic relapsing disease. So if you see also, patients with proper nutritional guidance and strength training, if they stick to it, great, they'll succeed.
Absolutely.
But as soon as they go back to old habits, you'll see that they'll yo-yo back, right back to that same weight. So what we realize, it's multifactorial. It's not just nutrition. It's not just lifestyle. I'm saying that they are very important components. But I think a big one is genetics, which we overlook sometimes. I also think another big factor is mental health in this whole cogwheel of obesity. A lot of patients tend to self-medicate with food, right? If they're anxious, they'll eat. If they're depressed, they'll eat. If they're happy, they'll eat. So it's that serotonin, dopamine, neurotransmitter type of reaction. So in our field, we realize that it's not just as simple as, just looking at the nutrition and lifestyle. You have to look at other things. And then the other big one is hormonal. And that's where I think medicine comes into play for a lot of patients. If we can fix the hormonal issue, we can make it easier for the patient to stick to a nutrition and lifestyle plan. If we don't fix the hormonal issue, they're going to keep yo-yoing.
Got it. So I think this is, now we're looking at it more holistically than what we used to be looking at it before. And yeah, I generally do feel that, usually people have this 0 to 1. Like, if I'm trying to lose weight, I'll stop eating. And that sort of just goes for a week or two. Then it's just, you're so frustrated by something not happening or the needle not moving. Then I know a lot of people who are in the same space, and I think that's where this and that thing comes in so well. So yeah, perfect, great. So, ma'am, you mentioned in some of your reels also that obesity is not always a choice. And more importantly, that as we were already discussing, that people sometimes, even when they're trying everything, it's not working out. Is there a specific incident or a patient that you can help us understand that how that's happened and what you've done to sort of maybe help them out?
Yeah, I think a lot of the patients who come in, they've either tried everything, like you mentioned, Sahil, or they've not tried anything. We get two ends of the spectrum. But a lot of times I've seen that a lot of patients don't know how to even go about proper way. So when a patient does come to me, they get proper guidance and whatever I can provide in nutrition, but we do a full hormonal check on them. So if someone, for example, has PCOS or has insulin resistance, no matter how much they try to lose the weight, their body's set point will always bring them back because we're not fixing the crux of the issue, which is insulin resistance. In other cases, I find that some people have overactive hunger hormones like ghrelin, or maybe underactive leptin, which is your fullness or satiety hormone. You'll find different variations in different people. So not one medication can fix that issue. I think each individual's genetic makeup is so different. So, for example, other patients come, I can never feel full, no matter what I do. No matter how much protein I eat, I'm always hungry, doc. So then we have to do a little bit more digging. Is this monogenic obesity? Meaning, have they been obese since a child? And we have to look at those causes as well and rule those out.
If they're obese as a child, again, how much of a role is it genetics? And we all know that the Indian diet is not the perfect diet. There are so many things which go wrong. Because I see a lot of people who are also obese and they're now trying to seek help maybe a little later, like for example in the late 20s or 30s. But the issue has been very visibly prevalent for a long time. So then why is this stage coming in so late to seek treatment? Is it because at that time it doesn't feel like, because I see a lot of kids, and as mothers or as parents, we want to make sure that hasta khelta bachcha lagna chahiye, khata pita bachcha lagna chahiye, chubby. So is that a very deep rooted issue which we have, that because I as a child was severely, I won't say severely, but I was underweight and I was a very lanky child. And there were some kids who were just, they had these very rasgulla types cheeks which they had. So are both ends equally dangerous basically?
So when we talk about monogenic obesity,
so can you just specify monogenic?
Yeah, so that's basically the individual is missing maybe a specific gene.
Okay.
Like for example, leptin resistance. And no matter what type of diet, no matter what type of initial medication you put them on, they're not able to lose the weight. And it's usually below the age of 5. So the history is very, very important for the individual. If the mother and father say, yes, since he was 1 year old, he struggled with obesity, then that kind of signals something to us.
Something is wrong.
Right. So we get our genetic counselor involved. Hey, let's do some genetic testing. There's a multitude of them. There's NC4 deficiency, conceive deficiency, leptin deficiency. There's a lot of them. Yeah. And the medications are different for them.
Got it.
And so once you administer the medication, the child starts to lose the weight. He starts feeling fuller. He starts, able to control his appetite. But anyone above the age of 5 who starts to struggle with their weight, and we are seeing a rise in childhood obesity, that's also a very prevalent topic.
Very, very prevalent.
Yeah. And I think a lot of it has to do with how sedentary we've become as a human race, number one. And of course, our diet. It is. It does go back down to the basics. I can't always blame the hormones. You know, like people will come looking for a reason.
Yeah.
It's my thyroid. I love that one. That's the best one. It's like, no, it's not just that. There is other stuff that we have to look at. So it's a holistic approach, like you said.
Got it. Perfect. So, ma'am, one of the main key points which you wanted to discuss in this podcast as well was that weight, based on what I've learned, is that plays a role in so many things. Sometimes things which you don't anticipate weight to play a role in. So, for example, fertility being one of them, where there seems to be a relation between weight gain or weight management and fertility. Both seem to very distant topics to sort of be related to, but there seems to be a relation between them. So, can you help us explain what exactly is it and how much of an impact does weight have on fertility?
So, there's a clear link. If you're underweight, you might have issues with your fertility. And if you're overweight or obese, you might have issues with your fertility.
Okay.
So what's the link in this case? If someone is struggling with obesity or overweight, the female, I'm going to speak about the female because gender specific, the female may have menstrual irregularities, which means anovulation. They're not ovulating. They're not every month, they're not ovulating because of insulin resistance, which can be high. And as a result, we'll also see certain other hormones like androgens in the body are on a higher level. And that will prevent proper ovulation every month. Ovulation is when the egg is released.
Absolutely, yeah.
So
if you can just specify more on the insulin resistance part of, again, when I'm supposing if I am on the higher side on the weight, then what is insulin resistance and how is it playing a role in the menstrual cycle?
So insulin resistance, I think this is a very important topic to understand. When we are exposed to high blood sugar levels in our body, so whenever we eat, and we're prolonged, like this prolonged exposure of high carbohydrate intake, high blood sugars in our body, insulin is released from the pancreas. It's a hormone. That insulin is basically binding to glucose and it's taking it either into the liver or to the muscle to be used or to be stored.
Got it.
Right? Now, in insulin resistance, what happens is if you can imagine insulin as a key and the doors to the cells it needs to enter. Open that door and allow glucose to enter the cell so that it could be reuptake, right? Insulin resistance happens when that key is jamming in there. The keyhole has become rusted. It's not able to enter. So as a result, glucose is building up outside the cell. The cell is not able to get the glucose.
So it's in the blood.
So that's why blood sugar levels go up, right? And then the cell is not getting the energy. So there's fatigue. The patient is tired. The patient is having sugar cravings because I need sugar, right? And as a result, insulin, the pancreas is still detecting high blood sugar. So it's pumping out more and more insulin. What do we see? Insulin's going up, blood sugar is going up. Eventually, this leads to prediabetes, which is average blood sugar that's running higher than normal. And then diabetes, where blood sugar levels are running very high. So this is insulin resistance. It's not an overnight thing, Sahil. It happens over a prolonged period of time. But what happens is there are no clinical signs and symptoms initially. As time goes on, we'll start seeing centripetal weight gain around the waist area. We'll start seeing hyperpigmentation around the back of the neck, the skin folds.
That's actually something which is very common as well,
Yeah, that we call that acanthosis nigricans. And that's another
So these are all symptoms of insulin resistance, so we know what we can understand.
Correct. And these tend to happen a little bit later down the line. But fatigue is a big one, but it's also very common, right? Other reasons for fatigue are there, but this is also, and that the reason is because the cells cannot get the energy, the glucose.
Got it.
So, and then how does this affect fertility? Now that's the next link, right?
So just before that, basically, so this which we're calling is type 2 diabetes.
Correct. This leads to type 2 diabetes, insulin resistance.
Got it. Perfect. And type 1 diabetes would be?
Type 1 diabetes is separate. The pancreas is not producing any insulin, very little to no insulin. Which is why oral medication doesn't work for type 1 diabetics typically. You need to inject insulin in order to control the blood.
The injections which, a lot of people take on a day-to-day basis, that would be for type 1 diabetes.
For type 1 diabetes. Yes. That's to produce enough insulin.
Great. So for fertility now, how does insulin resistance work with fertility?
So as insulin resistance is happening, elevated blood sugar levels, this leads to a chronic state of inflammation in the body. Not all inflammation is bad, right? If you have a cut, we want an inflammatory response so as to protect you, right? But if you have inflammation for a long period of time, you're going to be in a chronic inflamed state. And this can affect a couple of things in fertility. Number one, as your insulin levels are up, high blood sugar levels are up. So the follicles cannot develop properly for ovulation to happen, for egg release to happen. Number two, there's excess production of androgen, which is testosterone. So we'll see female pattern baldness, and we'll see facial hair growth, heavy facial hair growth. Along with that, the centripetal obesity. And then we'll also see the hyperpigmentation and no regular menstrual cycle. Some women can have regular menstrual cycles, it's not that, but they may not be ovulating.
Got it. So some of the symptoms which you just mentioned, because we do talk about PCOS very often. So some of these symptoms do seem to be very closely linked to PCOS as well. So is this something which is very natural to happen during PCOS?
Insulin resistance?
Yes.
Yes, it's one of the symptoms or one of the byproducts that we do see. I don't know if it's if the egg came before the chicken or the chicken before the egg, but they're 100% related. So most patients who have PCOS definitely have insulin resistance. And usually what I'll see is insulin resistance has led to this. So a lot of times doctors will be like, go lose some weight. But the PCOS patient is like, I'm struggling to lose the weight, you know? And that's where we have to be more empathetic towards our patient, give them the proper tools, you know, to help them achieve their goals, because otherwise they're going to keep struggling with it. They'll lose 5 kgs, they'll gain 5 kgs. That's what happens. And that means we haven't fixed the crux of the issue, which is insulin resistance.
So, for example, I am somebody who is struggling with weight. You know, I have an increased weight. Plus, I am also struggling with insulin resistance. So then the first option would be to fix the insulin resistance and then the weight? Or
so both will go hand in hand. As you are fixing the insulin resistance with maybe medication or even focus on nutrition and lifestyle, movement. Right? Remember that glucose that's running around? We want that glucose to be taken up by the muscles. So if I start even walking 10 minutes post my meals for 30-minute walks, you know, something to get myself moving, that glucose will be taken up by the cells.
Is it because it's requiring more glucose then? Is that the reason why?
The body? It's because, yes, your muscles are requiring it. So if you're sedentary, your muscles are not utilizing it. So it's getting stored.
Got it.
And insulin is a huge fat storage hormone as well. So the simple things you will start with. But obviously you have to keep changing it, right? Because that's when that weight regain can happen again.
Got it. So you also mentioned the concept of the centripetal fat. What exactly is that? So I'm understanding the different types of fat. So,
Well, there's visceral fat, there's ectopic fat, and there's subcutaneous fat.
Okay.
Subcutaneous fat is a fat so you and I can see, we can touch, we can pinch. Visceral fat and ectopic fat we cannot see because visceral fat's around the organs. Ectopic fat's around the organs as well. And we can only see with diagnostic modality, like a CT or an MRI. And that's what leads to centripetal obesity actually. It's the visceral fat that's depositing around your organs, giving rise to fatty liver, heart disease, stroke, cancers, diabetes. So this is the one that we want to reduce.
And this is the one which we can't see.
This is the one we can't see.
Got it. Okay, so I was watching a few of your reels, and in that I came across this concept called TOFI. It's thin fat outside and
thin outside, fat inside.
Thin outside, fat inside.
Fat inside,
So is that the similar concept from what this is, or is that a different concept?
It is similar in the sense that visceral fat is high in these individuals. So actually, Indians and Asians tend to be TOFI or TOFI, whatever you want to call it. I don't know the pronunciation. But what happens is these individuals have a smaller BMI or a less BMI, because they don't have as much muscle mass and they have more fat, right? So as a result, they have more visceral fat around their abdomen. So you would see like it's a phenotype. It's an Asian phenotype where we're seeing, you know, thin arms, thin legs, but a belly.
Yes, that's very common.
And that's a very common thing.
Very common thing.
And these individuals are at high risk for metabolic syndrome, diabetes, heart disease. Why are Asian men more prone to heart disease? Like I remember in the US reading studies, it's always the Indian men that had coronary heart vessel disease. They're more susceptible. Now, reasoning for this, you know, it's still being argued that it could be our diet, which is high carbohydrate, less protein. We have less muscle mass as a whole. And then there's also this, I think theory out there that we have or were in a famine state as a population in the Asian subcontinent. And as a result, our body is meant to store fat for energy.
Okay.
So there's a theory out there.
Okay.
But these are the typical reasons we see that.
Okay. Yeah, because that is something which I see very, very common, and it seems like, they are thin, but the muscle doesn't seem to be there, and which is the reason why they seem too lean to be able to have that strength to pick up anything and move forward.
Yeah.
Okay.
And these individuals also feel like, okay, I'm fine. I appear to be thin.
Yeah.
So nothing must be wrong with me.
Exactly. Yeah.
But that's where they're incorrect. So whenever they do their blood testing, which I always recommend, do an annual test, get your blood sugars checked, get your cholesterol checked, get your insulin checked.
Yeah.
And then that's a little bit elevated, or they have fatty liver. That's also very common here. Let me see.
So again, in fatty liver, I believe that happens because of multiple reasons. Alcohol seems to be one of the reasons why people have fatty liver, and food would be the next big reason. Is it, or is there other more?
So NASH, which is non-alcoholic steatohepatitis, also now known as MASH now, metabolic associated.
So many acronyms.
Yeah, so then they keep changing also, changing on us. So alcohol-induced fatty liver is separate.
Okay.
That is from inflammation, cirrhosis, and there are different grades for that. Most commonly, we'll see MASH now, which is metabolic associated steatohepatitis, which is fatty liver from having elevated triglycerides, elevated blood sugar levels, elevated cholesterol. Remember, liver is where blood sugar goes to get stored when it's not being used.
Okay.
So imagine someone who is obese. That blood sugar level is going there to get stored.
Yeah.
Imagine a room. That room is full now.
Yeah.
So what's going to happen? There's going to be inflammation around there. And that's what leads to fatty liver.
Fatty liver.
So if you remember it this way, you'll know what that association is as well.
Okay. That makes a lot of sense now. Okay. Got it. So you've also, since you mentioned being underweight also might be an issue for fertility.
Yeah.
So we've discussed the overweight concept.
Yeah.
Now for being underweight again, how does that play a role?
So if you're underweight, you will not menstruate regularly. It's a hypothalamic amenorrhea. So you're...
Okay, let's decode that. Okay.
So if you are underweight, there is again a hormonal imbalance there. So the female hormones will, from the pituitary gland in our brain, as a result, will be affected. And as a result, they won't be released and you won't ovulate appropriately. You won't even have periods properly. And that can be a cause for fertility issues. The other thing is, women forget this as well. It's not just about conception, right? You have to carry this
child with you for 9 months.
Right, and provide the proper nutrition to them. So either if you're underweight, you might struggle with that. Your baby might struggle with growth retardation, IUGR. Even in patients with obesity, you might notice macrosomic babies, large babies, gestational diabetes, problems with delivery, and also other fetal abnormalities. So I think, preconception counseling is really, really important, which I don't think a lot of women and men take very seriously. Like, okay, we're living our lives and now we want to have a child.
Yeah.
And I'm 30 now.
Yeah.
Oh no. So I have a short amount of time.
Absolutely.
And then, the pregnancy and then post the pregnancy.
Yeah.
Now I don't have the energy to take care of my child.
Yeah.
Right. So
I think it's because I'm 26, turning 27.
Yeah.
So a lot of my friends now, they are planning to get married.
Yeah.
Some of them are married.
Yeah.
But everybody, we go out, we see reels of, people going and having their best time of their life.
Yeah.
And when we talk to couples, all of them say that, things change after you have a baby.
Yeah.
So which is the reason why everybody wants to have this ye jawani hai diwani time with them of, 2.5, 3 years of just exploring.
Yeah.
Which means that it is almost inevitable that you would start thinking about a child at 30 or, maybe. So, in the tier 1 cities, this is anyways a trend that people are starting to think after 30, where every report which comes out says that 27 is the right age to get pregnant. It's in total desync. So I have two questions to based on what you mentioned. Number one is that I am seeing that there is a lot of things which be, from being underweight to being overweight, both play a huge role in the hormonal imbalance which women have. And this seems to be a very sort of like a sensitive scale which can just tip at any moment. So if somebody actually wants to make sure that I have ample of time to do corrective measures, to make sure that I am not facing these issues, what would you say is the right time to come to a gynecologist, come to a obesity specialist? What's the right age? Because today, maybe as a parent, you feel an 18-year-old is just too young. Like, this is to go to a doctor right now, all these things. So what's the right age here? And
Right. So I think it's a loaded question. And I think the answer is very individualistic.
Okay.
So, one can change their lifestyle, their nutrition, their habits at 18 to live a long, healthy life, right? I think that should be, at that age,
absolutely
their priority.
Yeah.
And obviously, if they continue that, then things will be good for their preconception, their pregnancy, and their post-pregnancy. But if, let's say, what's that saying? It's in Hindi, jab jago tab savera, right? Sorry, my Hindi is good. It's not that bad. But whenever you realize that, okay, wow, now I really need to get my life together. And it could be when you're getting married, or it could be after a year of marriage, right? I think take the time to understand balance. I can see a lot of patients, and they'll, like you said, it's an all or nothing approach. Like, I'll stop eating, I'll stop drinking alcohol, I'll stop doing everything. Though stopping alcohol is a great thing to do, I would say that find a fine-tuned balance in your life where you are incorporating good lifestyle measures. And if you're planning for a child, give yourself at least, I would say, 6 months to improve your health, improve your partner's health, improve your mental health, along with your physical health. They have a symbiotic relationship,
absolutely.
Right? So don't just focus on my physical aspects, focus on the mental preparation and give yourself the time. I don't think anything happens overnight. I get a lot of patients, doc, I have 3 months. I have 3 months to lose the weight. And I'm like, this is a marathon you're running. This is not a sprint. We really want to do it the right way. Because if you do it in a short period of time, Sahil, you're bound to rebound and gain the weight, right? So any measure takes a month to kind of stick to. After that, any habit that you want to continue will take 3 months. So I would say 6 months minimum.
Got it. And in this, again, we've been discussing the female aspect of the weight. But as we know that, a lot of the brunt of infertility is what the wife takes up, where men also have a huge role to play here. And mostly if you see unfortunate things, some of the bad habits, for example, as you can say, smoking, drinking, along with weight management issues is something which the husband suffers from as well. But when you think about fertility, just the natural thing is that, okay, the baby is inside her. So then how am I related to this? So how big of a, so we mentioned the coronary part, but from a fertility portion, how much does weight contribute towards a male fertility or infertility?
I think so. It's 50-50 partners, 50% from the female, 50% from the male. If you are overweight or obese, you're going to have more estrogen in you as a male, right? And as a result, you will struggle with decreased sperm motility and sperm quality. So absolutely, the female is giving the egg, the male is giving the sperm. So we need to be at a very equal ground here. The male has to take care of himself just as much as the female. And I think both of them also share that symbiotic relationship that, throughout the pregnancy, you'll see, the male gain weight along with the female. The same way, if the male is healthy with the female, then both of them as a couple will be healthy. And those same habits will go into the kids as well. So I would say, other than the sperm motility and mobility, the energy levels, the quality of the embryo, all that is also going to be affected by the sperm.
So if today a couple walks into your clinic and the weight for both of them are on the higher side, luckily they have come with some time in the hand, for example 6 months or maybe 8 months with them, and now they're wanting, okay, no doctor, what should we do? And if you do advise them something which sort of helps them also to lose weight, how much weight reduction are we looking at here to actually play a
significant
role in improving their fertility? Is it like 2 kgs, 5 kgs, 10 kgs?
So we look at it as a percentage.
Okay.
So 5 to 10% of weight loss can improve, from all the papers, it can improve fertility in women by 68%.
Oh my God.
Like, so that, just imagine just
Oh my
losing,
God,
if a
okay.
100 kg female and she loses 10 kgs, it's going to improve fertility by that much.
My God.
And
That's
it's
crazy.
a small amount. But again, I would say don't just focus on that. You have to focus on staying healthy throughout your pregnancy and continuing it postpartum as well. But we have found that significant fertility bump, especially in women who are struggling with obesity-related fertility issues like PCOS. So that can help them.
Got it. And in this case, like, since we've been mentioning weight, since that's it's one metric from a weighing scale.
Yeah.
What I've seen also you talking about is that BMI is also not the most holistic measure. So then what should be an ideal point? Because everybody has a weighing scale at home. Nobody has a BMI machine at home. So going up on the weighing scale, and if I'm doing so much with my health, I'm eating right, I'm sleeping right, I'm doing so much, I want to see that report card when I step on the weighing scale and see if that's moving.
Yeah.
And when that's not, I'm really disheartened.
Yeah.
So then what would you recommend to somebody who's on this journey?
Yeah.
What's the right thing to see, basically, and what should you not see, basically?
Right. So weight is one vital sign, right? But if you're strength training, Sahil, your weight, because muscle weighs more than fat,
it'll be increasing.
It's going to increase. So you may not see those exact numbers come down. And I understand it can be disheartening, but this is where measurements come in. So waist circumference, arm circumference, your metabolic panel, meaning how your blood sugars have improved, how your cholesterol has improved. Obviously, you can see these in 3 to 6 months.
Yeah.
The third thing is how you're feeling, right? If you're feeling more energetic, right, then you're doing something right. So I always tell my patients, we're lucky we have a body composition analysis in the office. So we can see how much muscle mass has increased or decreased, how much body fat has increased or decreased. And even fluid. If someone has a lot of inflammation, they'll have water retention. And I always tell my patients the first 4 weeks is all water weight. I'm happy that you're losing, but I just want you to know that's just all water weight.
Got it.
So it's going to take time. But I would always tell my patients, I also have a waist circumference measure. I tell them measure their waist, measure their hips, measure their problem areas.
So if we're measuring the waist or the hip, again, that's the fat which we can see. But the fat which we can't see, for that, again, what would be the right measure to make sure that, I'm moving in both directions well, and not just, is it that I'm doing something which is only reducing this and not the inner fat?
So your inner fat is going to also cause a slight increase in your waist circumference, right? Your visceral fat.
Yeah.
It's going to push on the subcutaneous fat. So if that's going down, my visceral fat is going down.
Okay.
And subcutaneous fat, it's a cosmetic fat for sure, but that can be toned with exercise as well. And you have other measures one can do as well, surgical and non-surgical. It's a combination effect that you're going to see.
Okay.
And a big thing I want to tell patients, and I'm bringing it up now because I think obesity used to be considered a cosmetic issue. I want to look
for
good.
For the longest time, yes, absolutely. Yeah.
That I want to look good. And there is a vanity factor. I don't think I'm ever going to dismiss that. But this is now a metabolic disease that, we have to look at it from that perspective. That if we want to live long, healthier lives, and we want to have that high energy level, then we have to look at it from that perspective, not just how we, what we're on the weighing scale and how we look. It is a factor. I will always say that because there has to do with,
absolutely
motivation.
But there's another part to it also. For example, if there are people who are very conscious of how they look, and that is where even sort of having a little bit of extra body fat percentage does really irritate them because they don't like to see that. On the other aspect, there are people like, हमको शाहरुख खान थोड़ी बनना है.
Right.
So it's okay if I have a belly, if I have some belly fat, it's not like I'm going to go and model, but that has more problems or issues than just cosmetic.
Right.
It has inner problems which are also affecting. So I feel that awareness should also be coming that this is not just a cosmetic problem. This is way more which you are not being able to see, which is happening.
Correct. Absolutely.
Got it. So I'm going to come at the most. I'm a Marwadi, so I'm going to be coming at the most Marwadi way of solving an obesity issue, which is that Baki, I'm having ghar ka khana, so see, everything anyway seems to be fine with me. We will come to the food aspect of it, but okay, if I want to lose weight, let me go to the gym or let me go on a walk. We've got a beautiful Victoria here, so we go on either a walk or I'm gonna go and I'm gonna burn myself out in the gym with just doing as much as cardio as someone can humanly imagine. Why does that work and why doesn't that work? Because you've mentioned strength training a lot, and I feel this is something which is, these are two very different things. And why aren't we talking about cardio here in that case, that compared to strength training?
I think cardio is a must as well. I'm not saying that we should stop cardiovascular activity at all, because that's important for the heart. However, what we found is that if you don't have enough muscle mass, you will hit a plateau much sooner, right? So whenever we lose weight, we will lose some muscle mass, we will lose some fat, no matter what you're doing, by the way, nutrition, exercise, running around. As our muscle mass goes down, our body hits what we call like this set point where it won't let you burn anymore.
Okay.
It will probably plateau because muscle requires more energy, right? If we're not building on that, we're going to have difficulty losing more fat. You will hit a roadblock.
Okay.
So when we strength train, we help to increase that muscle mass. Now remember, the basic building block for building muscle is protein.
Yeah.
So, for my patient who comes in, if you're not eating enough protein and you're just doing cardio and eating carbs, you're not doing justice to yourself. You're going to lose a lot of muscle mass, which is going to be detrimental.
So actually you're training, your strength training, for example, something which the doctor told you to do and you're doing that. But if you're not having enough protein, then it might work in the opposite direction for you.
It's not going to work for you. Okay. So you're going to see that I'm doing all this. Yeah, you're going to have muscle fatigue and your muscle mass is not going up either. So a lot of individuals, they're seeing the weight loss, but that's the water weight loss, maybe some fat loss, but they're seeing muscle masses. The skin is drooping, it's sagging, right?
Yeah.
So that's why checking in regularly, getting a body composition once in a while helps to kind of make sure that I'm hitting the right parameters. And eating adequate protein will hopefully keep that muscle mass up as well. And you can also build on that.
Okay. So when you're saying strength training, is it primarily from a point of view that, okay, I'm trying to do some strenuous activity, which is breaking down the muscle, or, at least giving that sort of strenuous push to my body? The reason why I'm asking this is because we've got like hitting the gym where, I'm doing some sort of like weighted or, body weight activity or like a dumbbell or something like that.
Yeah.
I've got yoga, I've got walking, I've got jogging. So what exactly constitutes as strength training basically, and what hits the parameter?
So strength training can be done with body weight exercises as well. You can do yoga, you can do calisthenics, you can do Pilates. But if we want to build muscle, then I always recommend you need to lift. If you don't lift, you won't build. And if you continue to do body weight, you'll maintain that. But you can also build a bit, but not to that level that I would want you to.
Got it.
The biggest marker for longevity right now, Sahil, is muscle mass. And you can see it in our geriatric patients, actually. So medicine is, from pediatric to geriatric. The patients who do the best in their geriatric age are the ones who have been physically active and strength training. Because with age, a lot of things are going to change. We're going to talk about perimenopause and menopause, right? Women's muscle mass is going to go down, fat's going to go up, even for men with changes. And if they don't build muscle, you're more prone to fractures. And that's the downfall in the geriatric age group.
So just based on the topic, if supposing I don't have enough muscles, then that's not supporting the bone. So and plus osteoporosis is weakening the bone as well. So it's a dual effect which is happening to sort of putting me in an even more difficult position
in a
than
more
what
difficult position. Correct. So, and then they're at a geriatric age also, you'll find patients don't eat as much, right? They don't have that kind of appetite that they used to. Also, they're not moving as much. So these things are important to look at as well. So each individual has a very different requirement. Your protein requirements are much different from mine.
Absolutely.
And your grandmother's protein requirements will be very different from yours.
Got it. Right. So when you mention, for example, strength training, and the entire point of, okay, let me go and let me lift any sort of body weight seems very alarming to a lot of people, especially, for example, even women's, because the gym has always been a place where, okay, let me go and make Salman Khan type of a body and, have these pumping arms. But that's very different from what the gym, which we are trying to, the kind of regime which we're trying to picture. So, have you seen this to be very common among women? And if somebody comes and tells you that, I don't want to, get these bulk arm, etc., what do you tell them? How do you convince them?
So I tell them that you are not going to bulk up like that. I mean, unless you are aiming for that. You have to have that certain protein requirement and you need to strength train like that in order to reach that level. So it's a big myth, right? So it's myth busting with the patients. I find that a lot of women are more open-minded now about working out and strength training. So I'm seeing this transition. Maybe it's the age group, maybe it's the awareness now, but a lot of women they're open to it. My biggest downfall comes with the obese patients. They're afraid, number one, and rightfully so. I don't want to injure them. So if you're starting on your journey, anywhere, and you're struggling with your weight, start slow. And always get someone who is trained, properly to train you, because we want to prevent injury. A lot of patients will go, first day, I want to go start lifting. Please don't do that. Warm your muscles up, then work your way up. And I always tell my patients, first lose some weight. Take the weight off of yourself a little bit, a month or two, by focusing on nutrition, and then start.
So actually, somebody is on the higher side on the weight. If somebody is obese and they don't have enough muscle, then the muscle is doing an overtime work of not just what you're lifting as a weight, but also your body weight, which is really a lot for the muscle to take in because it's not strong enough. Got it.
And muscle fatigue, electrolyte depletion. They're not going to go back to the gym the next day because it hurts. Everything hurts. And rightfully so. So that's why start slow. Work with someone you trust, someone that can work with you as well, and then go from there. But slow and steady. I always say you're running a marathon. You're not running a sprint.
Okay. So we're now going to come to the most burning topic in the country, which is GLP-1. And that's something which is on every news headline. That is something which is on every YouTube video, every podcaster, every YouTuber, every influencer is talking about one thing, which is GLP-1. And this is something which, we live in a time where previously this wasn't possible. Previously, everybody thought the only way was the hard way. And now there seems to be this very fancy, it's like almost, this dreamy way of being able to get the right body which I want to. So what is GLP-1 firstly for the audience, and what exactly does it do?
So GLP-1 medications are peptides. Basically, we actually make GLP-1. You and I both make it, and the medication helps to increase the level of the GLP-1 hormone. This is our satiety hormone, meaning after this increases, you tend to feel full.
Got it.
So as a result, you'll be able to maintain a caloric restriction because you're not as hungry anymore and you're not having as many cravings as well. So patients start to lose the weight that way. It also helps at a hormonal level, Sahil. So insulin resistance, it helps with that. It also delays gastric emptying, which promotes satiety as well. And along with it, we are finding that it reduces inflammation in the body, which is huge.
So it's sort of working on all three parameters of what we're trying to solve for.
Yeah, exactly. So I always say it's a tool for my patients. It does not substitute nutrition and exercise. So your basic backbone stays the same. This is a very helpful tool. We're very lucky that this is also something that's available to our patients. I don't even think it's replacing bariatric surgery, by the way. I think it's something that it can be used in conjunction with it.
For example, somebody has an obesity issue, and I'm seeing two options here. One is a bariatric surgery versus one is GLP-1. In which case, what I should choose either or, basically.
Right. So that's great. That's a very good question, very relevant. Someone who's morbidly obese, like I'm talking 150 kgs, that individual, if they're willing to, will greatly benefit from bariatric surgery. What is bariatric? I mean, there are different types of bariatric.
You can explain that.
Yeah, there are different types. You can do a vertical sleeve, you can do a Roux-en-Y, you can do lap band. Not many individuals are doing that. There's also the balloon method as well. So that is a discussion to have with your bariatric surgeon, what you would qualify for.
The basic premise is to remove fat from the body, basically, right?
The basic premise of bariatric surgery is to reduce, again, the size of the stomach so that you are not able to overeat. And as a result, again, go into a caloric restriction. GLP-1 medications don't work for everyone, Sahil. That's where that premise comes from. Remember, I talked about monogenic obesity in the beginning. GLP-1 medications may not work for those patients. And I've had a handful of non-responders as well, where it's not working for them. And that's where bariatric surgery comes in to be a crucial life-saving method for this individual, right? Who's 150 kgs, has obstructive sleep apnea, has diabetes, has heart disease, might have some blockages. So I would look at that individual and I'd say, listen, we need to really consider this. All measures are on the table. Some patients will say, I want to try GLP-1. Absolutely. If there's no contraindications, we go through the side effects, you qualify, we will do that as well. We'll try it. But if it fails for some reason, please let's put bariatric surgery back on the table. Let's talk about it.
Got it. With GLP-1, supposing, now you must be having a varied range of patients coming to you. Now, supposing if somebody is at like maybe 85 kgs and they just want to lower down 5 more kgs or, just more from a cosmetic reason versus somebody who's much higher on the weighing scale, who would you advise GLP-1 to, and who would you say, okay, no, I don't think this is for you? Like, and is there some sort of a stage-based mechanism here of,
Right. So, all the studies have cutoffs. And I don't like the cutoffs because they're BMI. And we talked about BMI, right? BMI doesn't really tell us the whole health of the patient. But what I look at is the metabolic parameters, meaning is my patient, what are the lab work show? What has their journey been so far? If they tell me, doc, I've been trying to lose weight for the longest period of time and I struggle, then that's a different story. But if someone comes to me, I just need to lose 5 kgs for a wedding, I'm not going to recommend the GLP-1 medication to them because there's side effects. And I have to also see, do they qualify for it? If they understand the risks, the benefits, everything, then it's something we can talk about. However, you have to understand that taking a medication like a GLP-1 sometimes needs to be long-term. So if you're doing it short-term, there's a good chance as soon as you stop the medication, your appetite and hunger might come back and you might rebound. And that's where the whole holistic measures come in. That without proper nutritional guidance, without physical activity, I'm not going to recommend a GLP-1 medication. I think these measures have to be in place. Also, whenever we see a patient, we also have them do some cognitive testing, mental health testing. Is this patient struggling with depression, anxiety, body dysmorphic disorder? We have to look at everything. And the first thing is do no harm to the patient, right? So looking at everything, only then do we make a sound decision. If you ask my patients, they're always weigh in. They will always have a say in their decision. Nahi dog, ye nahi theek laga, ya ye dog, acha theek hai, how can I make this better? So a lot of patients come very open-minded. Some people are not so much. But it's a very sound decision we have to make.
So, but what I'm understanding is that because it's such a new space, the government guidelines, they haven't set any strict protocols of, this is below this you cannot recommend. So I think it's more on each physician's or each doctor's own judgment, which might also mean that some people who might not need it might be taking it either way, basically.
So here's the other thing. We get patients with a BMI of, let's say, 21, right? And again, I don't want to go by that BMI, but for Indian patients, BMI 23 and above is considered overweight or obese, right? So if someone comes in with a BMI of 21, let's say a 65-year-old female, but she's type 2 diabetic, right? And her A1C is high, it's 10. So the GLP-1 medication is actually not a bad choice for her because it's also going to control her blood sugar levels. We have to remember that. But with proper guidance. See, I don't want muscle mass loss in the 65-year-olds, right? She is a little bit on the smaller, leaner side, but she's also probably your TOFI, right? She's got high visceral fat in her. So in this case, it is not a bad idea for her, which is why that BMI cutoff we cannot use all the time. It's at the doctor's discretion, I think, and a conversation with the patient.
And because when I keep seeing these reels and there's so many celebrities who have also started openly coming out. I know Serena Williams, I saw reel Karan Johar also, that people are saying that they have started using GLP-1 and that has started helping them. With some people who I know who are using it, I do see while they're getting leaner, they are also getting too lean in terms of, you can see the face getting little too squeezed in, basically.
The Ozempic face.
Yes, the Ozempic face.
Yeah.
So again, why is that happening? And how can you, if you're on Ozempic, then how can you mitigate that?
See, so that sometimes is not our priority as a doctor, like looking at that. But I will always address it. I'm looking at more their metabolic health. But if I have a patient who, see, it's buccal fat, right, that goes down.
What
so within your face,
Okay.
that goes down.
Okay.
And it could be because of the caloric restriction and, you know, how you're eating. Sometimes it could be a more toned face. But what happens with age is skin sags,
Yes.
right? And with fat loss also, you'll see that the skin will sag. You will get, you know, sagging belly a little bit. But if you are toning throughout, you're exercising throughout, that can be somewhat prevented.
Okay.
It depends on the degree of weight that you're losing. So if someone is losing a lot of weight, we can expect skin folds to sag. From here, I would say it depends on the individual, but there are modalities to help you, you know, eating enough protein, eating enough collagen, getting a lot of superoxidants in, that can help. But you might still notice a little bit of a sag.
Okay, got it. And we mentioned GLP-1 for a more general case, but now coming to pregnancy or for fertility, since this is a very high stakes situation also, are you recommending it currently to patients, and to what degree?
So GLP-1 medications in fertility can be helpful in that preconception period, Sahil.
Okay.
Very helpful, especially in patients who are struggling with PCOS, and even in my male patients who are struggling with their weight, right? There is a washout period that we discussed with patients. Actually, there's a lot of research evolving in this area right now. And I know there's a lot of data coming and a lot of studies coming in a positive way. But I would say the guidance is, yes, you can use it under proper guidance and timing. So usually we recommend, depending on which GLP-1 the patient is taking, either stopping 4 to 8 weeks before you try to conceive.
Okay.
Right? Now, with GLP-1 medications, I don't ever recommend stopping abruptly. There should be a plan.
Okay.
You know, so that has to be discussed with your doctor as well, how to come off of it so that rebound weight gain doesn't happen, and the lifestyle and nutritional changes along with it. Right? But there is a window that you can absolutely start to try after that, after stopping the GLP-1. So yes, we are utilizing it in a very safe, systematic way.
Okay. And when you mentioned that, you know, going off a bit slowly, so is it, for example, a certain dosage and you keep decreasing the dosage? So maybe if my hunger pangs are on a scale of 1 to 10, they're at 10 right now, maybe they come at 3. Like, you know, is there some sort of how do you go off of it slowly?
So it's an individualistic response.
Okay.
So we have to see how the individual is doing, where their body weight is at, what their muscle mass is, what their protein intake is. So it's a full analysis.
Okay.
When we hit maintenance, I tell my patients, this is probably the toughest part of your weight loss journey. Like, you will lose weight initially. I know that. I'm very confident. But the maintenance is key. Whenever I tell patients about, they'll come in and say, Doc, how long do I have to be on this GLP-1? That's a big question that they have for me. And it's a very rightful, very good question. I always say, you know, the scaffolding that we have on buildings when we're making a building. So imagine GLP-1 use as a scaffolding. You're putting it up to help you build this building, right? It is a tool that's helping you. Now, as you're making the foundation strong, with the help of the medication, with the help of the scaffolding, with the nutrition, the lifestyle, the behavioral modifications, the hormonal help, your building is coming up and the foundation is strong. We could talk about weaning off the medication, where maybe you're not taking it weekly, maybe you're spacing it out. You know, the microdosing phenomena, and there's studies coming up on this.
Okay.
There's actually a latest study where they're saying utilizing it every 2 weeks has actually showed better
spacing
weight.
it out more and more.
Yeah, it's showing better weight maintenance. I mean, I'm waiting on the analysis from that study, but I know this is in the pipeline.
Okay.
So that's one method. The other method is maybe, yes, like my hunger needs to be controlled. Like my 150 kg gentleman, you know, I tell him that this is probably a long-term medication for you, right? Because the weight regain for you is more dangerous than you know, staying on this medication long-term. So that scaffolding is what I say the GLP-1 uses. It's there for maintenance purposes. It can either come back on when you need it, if you feel like things are not going as well as they were, or it could always stay there a little bit while we're still building on it.
Got it. Okay. That makes a lot of sense. Thank you. There's so many, because I believe that now currently GLP-1 comes as a injection?
So we have oral formulation as well.
Okay.
Oral semaglutide, and we have injectables as well.
Okay. I think that a new pill format is also something which is just starting to.
So we've had in India, we've had oral ribellicis
Okay.
for a long time.
Okay.
And now we have higher doses available in the form of oral Wegovy, which was approved for obesity. So ribellicis was approved for diabetics.
Diabetics.
And now we have Wegovy oral, which is approved, which is again semaglutide, same compound, but it's approved for obesity now.
Okay. So what's the difference between GLP-1 and semaglutide?
So GLP-1 semaglutide is a GLP-1 receptor agonist.
Okay.
The other one that we have right now in the market is tirzepatide.
Okay.
Tirzepatide is a GLP-1 plus a GIP, which is gastric inhibitory protein receptor agonist.
Okay.
So it's a dual receptor agonist.
Okay.
With this, we do see patients in respect to weight loss do a little bit better in comparison to semaglutide.
So it's like a upgrade from.
It's kind of like an upgrade. I call it the newer molecule, the newer and upgraded molecule.
Okay.
Some patients also we've seen have fewer side effects on it in comparison to semaglutide.
Okay.
And there are more molecules coming. There's a triple agonist coming, which is rituatride, which has glucagon in it as well.
Okay.
So this space it's really advancing.
And rapidly.
Rapidly.
Okay. Yeah. Got it. So we've spoken about a lot of topics, from inflammation, from insulin resistance to protein deficiency. So now coming to supplements.
Yes.
What role do supplements play in the advice that you give? And what are some common supplements which you see you are recommending constantly to somebody who's on this journey?
So, it varies depending on where they are in their journey. So if it's for fertility, I'm always recommending all the omega-3, CoQ10, iron if they need it, D3 if they need it. There's also other supplements like B12 if they're deficient in it. These are and then folic acid if they're trying to get pregnant. That's the main one that we always recommend to them.
So omega-3, vitamin D, iron are some common ones which people know that they should be taking.
Yeah.
Coenzyme Q10 is something which is more of something which not everybody knows why you should be taking it.
Yeah.
So what exactly does coenzyme Q10 help with?
So CoQ10 is a great molecule that helps in fertility. It helps with ovulation. It helps to reduce inflammation. Sometimes I give CoQ10 when I put patients on statins also.
Okay.
So because it helps to reduce myalgias. Statins are for cholesterol.
Okay.
So like atorvastatin, rosuvastatin. So these medications, we always give CoQ10 with it. It reduces the inflammation that can happen as a result of it as well. So I think it's a great supplement to be on. Of course, with the right dose and the right reasons.
Reasons, yes.
Yeah.
Got it. Perfect. And apart from this, since we've been mentioning protein, so what's the amount of protein which somebody should be taking?
So that depends on the individual as well. So, and the purpose. And usually, there is a calculation like it should be 1.2 to 1.5 grams per kilogram is the recommendation. I usually tell my patients if they're on a weight loss journey, then try to hit anywhere between 80 to 100 grams of protein. Ballpark figure. This is where you need to hit. The Indian vegetarian diet is difficult. Mushkil se, I think 50 grams protein milta hai day mein. Let's be honest. I also struggle with it myself being a vegetarian. So I need to supplement with protein, and whatever suits me, I will take. So what I've found for fertility patients is plant-based is always better. And we've actually seen in our studies that even eating plant-based foods is much better than eating animal-based.
Is this from a gut health perspective which you're mentioning, or from a hormonal perspective?
I think this is a combination, to be very honest. So whenever we see plant-based protein or plant-based foods, we're looking from an antioxidant perspective, right? I want to reduce the inflammation in the individual's body. Sometimes red meats and meats in general can cause an inflammatory response as well, specifically red meat because of the fat content in it. So what I've seen, if you're on a fertility journey, there are some papers that say, look, if you are eating more plant-based proteins, plant-based supplements, and even plant-based foods, that can help reduce inflammation and help increase fertility. The other aspect is fiber. So when you eat whole grains, you eat dals, you eat lots of salads and fruits, that prebiotic aspect helps with the gut health.
Okay.
So I think gut health is key, no matter what, in weight also, obesity also, and in fertility also.
So just I'm digressing from the topic, but for
Yeah.
example, with gut health,
Yeah.
now there is not a single person who I know who doesn't have
gut
gut health issues.
Yeah.
And like somebody suffering from just like, my body doesn't take it well.
Yeah.
Somebody's like, okay, I'm constantly having this bloating.
Yeah.
So if I have improper gut health,
Yeah.
then how does that change the entire perspective of me doing other stuff? Does it still help, or is it ineffective basically?
Doing other stuff meaning?
Like for example, like I'm eating right, I'm having the right protein, I'm having the right like
And you're still having gut issues.
I'm still having gut issues.
Right. Then you need to get evaluated. There's something going on. Maybe it's a food intolerance that you're not aware of. A lot of patients will be like, I eat paneer, I eat chena, and I'm so bloated after that.
Yeah.
Maybe it's a lactose intolerance that's not getting picked up. Maybe it's a gluten sensitivity. These are the most common ones.
Yeah.
Sometimes patients take it off just for the sake of it. That, oh, my friend took it off and she's doing much better. So sometimes I have to tell them, listen, first evaluate yourself. Keep a food journal. Let's go to the basics. See what upsets your stomach, what doesn't upset your stomach. You'll have a realization from there. It's always in the history. I always tell my patients, it's always, and that's why sometimes my visits are a little bit long, but I get a lot of information from them. And it helps me help them.
Got it.
If that's pursuing, like if that, even with that history, we're not able to figure out what's happening, then we can do a gut reset, or we can do more investigative studies, like checking for certain bacteria, like H. pylori, and finding out if that's a possible cause or not. And then, of course, maybe the type of supplements they're taking is upsetting your stomach, like whey in some cases.
Even like, I was actually seeing this map of India where I'm lactose intolerant. So, this is something which I didn't have as a child. But as I started growing up, I started realizing that it's like, I'm getting acne, I'm having poor gut health. And I saw this map of India where Punjab, Haryana, those areas are actually very tolerant to lactose because they just have so much dairy. While actually the eastern part of India is not actually very, very lactose tolerant. And so that was a very interesting thing to see. A lot of people don't know that, they might be lactose intolerant.
Yeah, exactly.
Yeah.
It has a lot to do with the gut bacteria also. I think there are emerging studies with gut bacteria, but there's this phenomena called leaky gut. Because of inflammation, the permeability of the gut membrane is weak, right? Because of chronic inflammation. Stress is also a chronic inflammatory mediator, right? And we take that very lightly. Like, oh, I only sleep 4 or 5 hours, I'm fine,
So when you say permeability, it doesn't mean that if I'm having some food, the goodness of the food is not going to my body?
Right.
Is that
so
what it means?
It's leaking, right?
Okay.
So if you imagine, I'm not sure if you remember, but from physiology or biology, the gut membrane has a microvilli. There's microvilli, right? Where the gut is absorbing nutrients.
The small dandelion sort of.
Yeah, they're like these pathways. And so a lot of the absorption of nutrients happen in the gut. Usually in the upper part of the gut, a lot of water reabsorption happens in the colon.
Got it.
So if there is inflammation, the membrane is very, how should I say, not strong.
Okay.
And so as there's a lot of nutrients can leak out because of that issue. And so there's a lot of malabsorption that can happen. So patients with celiac might have malabsorption. They may not absorb nutrients properly. Celiac would be, a gluten issue. But also we'll see iron deficiency, right? Because that's where all the iron absorbs in the upper part of the gut. So these are key things that I look for. So sometimes they'll be like, why are you checking my supplement level? Like, because I find out a lot of information from that. And it's
painting the more fuller picture, basically.
Yeah. Sometimes it takes too much energy to explain it. Sometimes we just order it and then we go from there.
Just from the last part of this podcast, looking ahead, what are some things which you look forward to in this industry? Something which you feel you see changing the next 4 or 5 years, and something which might actually change this space very radically?
In obesity?
In obesity.
So there's a lot of new molecules coming, which I was telling you about earlier. So I'm very excited about that because I'm curious to see how they work and how much better are they, because from all the trials, we're seeing a lot of better results. The other thing I'm also very excited to see is about how we will be able to utilize these medications to help with fertility and women's health. Because this is a lot of us doctors are really looking at this from a different perspective to help our patients. So that is what excites me. What I would like to see is a public health reform for obesity. Influencers are talking a lot. Doctors are trying to talk by being influencers. We're trying to do our job to get rid of the misinformation that's on social media. But I think, and we're also seeing pharmaceutical companies, putting a lot of information out there as well. So what I would love to see from the government and the public health sector is more talk on obesity and addressing it at a school level even.
Got it.
I think that comes from the fashion of seeing obesity from pediatric to geriatric. And if it comes from a better place, with more institutionalized things, like in school, better food, right? Better seminars for the kids, getting down
solve it more at a grassroots level then.
Yes, I think that will be more of a game changer for, I think the world. Not just our nation, not just India. But I think that it has to come from that level. And it's not yet coming from there.
Got it. So you mentioned an interesting point that, we have a lot of people now online talking about health. Some are talking things which make sense. Some might not. Is there something which you've come across which frustrates you, and something which you feel is not correct information, which at least the audience here can understand?
I think information on social media should always be taken with a grain of salt. Why? Because it's always one-sided perspective. I even tell my patients sometimes, don't trust me. Go do your own research. We are all educated and we can. And in the world of ChatGPT and AI, my patients come Googling everything. They're there to quiz me from day one. And I don't mind that. I actually really appreciate that. When you come with a list of questions, I know you've done your homework. And I love when someone does challenge me, because then I know that they're ready for this journey. You've come here well prepared. And you're going to succeed. I know that also. I do think there's a lot of controversial things on social media. I wish people, would stick to what they know, and maybe, not present things that they may not have sound knowledge on. I think that would be due diligence, meaning to the patient, right? So, not to step on anyone's feet. I'm also on social media, and maybe someone can call me out and say, you said an incorrect thing. I'll take it. I'll say, yeah, maybe I was wrong on that front, and I'm sorry. And maybe I'll, retract it and put something else out there.
Got it.
So I'm open like that. And I understand it's a platform now. I get it. And I get people are on there and they're trying their best to do whatever they are. But I think more doctors should go on there, and they should bust myths. And they should, because they're experts in that, right? So their knowledge is definitely much more. Like their clinical experience.
The context is more.
The context is more. Same way with a nutritionist. I will say, my nutritionist knows way more about nutrition than I do. That's more of an interest. My physical trainer knows way more about physical training. I cannot do what he does. My health coach knows how to talk to people, motivational interviewing. He knows, or she knows, how to speak to them. So I'm not going to step on his toes.
And doing that all together actually doesn't give the right approach, or doesn't give the most specialized approach to the patient either way. If you try to do all of it yourself.
You try to do it all yourself, you're not doing justice to anyone. Absolutely. So stick to whatever you know and go from there. I think that's what.
Perfect. Okay. So we're at the final stage, the aakhri padav of the podcast, which is the rapid fire round. I will be asking you a series of questions, and you need to just hold up the card and say if it's a myth or a fact.
Okay.
Cardio is the best exercise for losing weight and keeping it off. Myth. Okay. Walking for just 10 minutes after a meal can actually help you lower blood sugar.
Fact.
Okay, great. Stress is just a mental thing. It doesn't cause physical weight gain.
Myth. Stress is a big factor for inflammation, chronic inflammation, insulin resistance. If you're not sleeping, you're stressing yourself out, and it can increase cortisol levels and as a result, insulin levels, and cause more detrimental side effects.
Okay. Some types of cholesterol are entirely genetic. No amount of diet or exercise will fix them.
So there is something called lipoprotein A, which is a marker for bad cholesterol. It's a little bit different from LDL.
Okay.
And what we found is there are medications coming to target that bad cholesterol. They're not out yet.
Okay.
Statins may or may not work against them as well. And even nutrition and lifestyle may not help with it. So this is basically putting you at risk for developing coronary artery disease, stroke, other medical comorbidities as well. So this is something that one should get tested for once in their life for now. But if we don't have anything to trend it down.
Okay. Fat-free and low-fat foods are always the healthier choice.
So myth, because I think not all fat is bad. So we have good fats like avocados, nuts, fish provide us good fats as well, and olive oil. So I would say balance, but absolutely avoid trans fats if you can, but incorporate good fats wherever you can.
Okay, perfect. Detox teas, cleanses, and juice resets can flush out toxins and reset your metabolism.
No, nothing,
Okay.
nothing can detox you.
I also have the detox teas sometimes. I'm like, okay, wow. Okay. So, where does the juice actually help, and when does it help?
So I am someone who says that, hey, if you can eat the fruit, please eat the fruit because it provides the fiber and it provides the good bacteria also to your gut, which is a prebiotic to your probiotic. For me, if you're juicing, have it with the pulp if you enjoy that. But for me, drinking just juice, I think it's just sugar. I don't think you're doing anything other than for your...
currently just having juice in the morning.
Yeah, and it's a more of a taste bud thing than it is a nutrition thing.
Okay, got it. So, just another question on that. So, I keep hearing these different types of juices: A, B, C, B, C, D, types of like.
If you're having it with the pulp, then it's fine. But if you're not having it with the pulp, like there are also some studies that have seen with the pulp, and if you were to eat the whole fruit. So eating the whole fruit is definitely better. But will you eat all three of those things?
Yeah.
Like that's the thing.
So the concept is that the fiber helps slow down the glucose absorption. Like, the spike is not as quick, basically, as it is.
Correct. The same thing you could do with protein. So add a protein to your nutrition plan. Like eat a fruit with a protein shake.
Okay. Yes.
So that it doesn't cause that sugar spike.
Sugar spike. Got it. Perfect. We've got, next question which we've got is, artificial sweeteners are completely safe, guilt-free swap for sugar when you're trying to lose weight?
So I am on the fence with this one. Okay. So I am someone, if you're a diabetic and you would rather have a Diet Coke over a Coke, I'd say go for that, because the Coke is going to give you too much sugar.
Yeah.
The Diet Coke has artificial sweetener.
Yeah.
Artificial sweeteners, when taken in excess, however, can cause gut issues. That we have seen because it's a chemical. So I would say, again, balance. If you're having a Diet Coke once a week, you're okay. I'm not going to fault you for it. But if you're having a lot of artificial sweeteners on a daily basis, you might have gut issues.
Got it. And I think the reels which I'm also coming across is that artificial sweeteners anyways in a very small percentage. So to go excess on it, you need to have a lot. Although we do use natural sweeteners, but even with artificial sweeteners, I don't think it's that bad of a picture as people paint it compared to sugar.
Exactly. That's what I'm saying. If you're drinking a Coke every day and you switch to Diet Coke, I'm actually okay with it. Because you're not putting that much sugar in you. But I'll still say if you can avoid artificial sweeteners, great. If you cannot, then it's better than having sugar.
Perfect. Fatty liver disease only happens to people who drink a lot of alcohol.
Myth. So like we discussed.
Yes.
That, no.
Eating at regular intervals of 4 to 5 hours can generally reduce nausea and side effects when you're on GLP-1 medication.
It can, in certain cases, I think, but it depends on the individual. So if you are really not hungry on a GLP-1 medication, I'm not going to force you to eat. But make sure that gap doesn't get too prolonged.
Got it.
So, certain patients, they forget to eat, which is a very common phenomena. So I tell them, set an alarm on your phone to go up every 5 hours. So it reminds you to drink water and eat something. But some patients will be like, I cannot. It's a new dose for me or it's too high. then I'd say it's okay. But if you do eat at regular intervals, it'll help with the blood sugar.
Got it. Your body actually burns more calories just from digesting protein than it does from digesting carbs.
Protein does have a higher thermogenic index, yes. So it does require more energy to burn. So yeah, fact.
Got it. So if you're like if you're strength training and you're having protein, then you're probably burning calories at a much better pace because both are helping you burn calories.
Right.
Got it. Perfect. Intermittent fasting is a great option for everybody.
I think intermittent fasting is a good option for certain people and may not be good for others. It may not be for everyone. Let's put it that way.
Okay. Who does it work for?
If you're doing it properly, I think it could work for majority. When I say doing it properly, I mean you in that window, you need to meet your macro and micronutrient requirement. If you are not meeting it, you're going to hit a plateau. Remember? Otherwise, your body's going to slow down. The metabolism is going to slow down.
So like in a vegetarian diet, if I get the entire day to fulfill my protein intake, now I only get that window. So the amount of protein I should need to be pumping into my body during that time is, it might not be for everyone, but who can have it, great.
Not only protein, but even the micronutrients as well, because I've seen levels drop. As a result, they're not eating and they're not hydrating also properly.
Got it. Perfect. Last question. Eating carbs at night causes weight gain. You should stop eating them after 6 p.m.
No, myth. I think carbs are not the devil. I always tell my patients that carbs are good for you. You need them. Basic building blocks. What I would love for you to do is walk after your meal. That would be great because it'll drive that sugar spike down, right? Because the glucose gets taken up by the muscles. So I think you can eat carbs. Have a cutoff though. After 8 o'clock at night, I'm not going to eat anymore. If I can avoid it, great. If I can't, I'll go for a walk afterwards.
Got it. Perfect. I think that brings us to the end of the podcast. Thank you so much for coming to the show. We are so delighted to have you here, and it was such a pleasure.
It was fun. Thank you so much for having me.
Thank you.